So for today's Pearl, I'm going to make it a little personal. So, who's my favorite person in the whole world? It's my mom. Yep, I'm gonna be honest with you. And as all of us get older, little diseases pop up here and there. And this one's not a little disease, but this is something I'm very passionate about. My mom got achalasia and she presented with dysphagia. And it was something that surprised all of us. And of course, the minute someone you love has a disease, you will become an expert because you got to be their advocate. You got to make sure they go to the right people, So when we talk about achalasia, the most common cause in the United States is, I don't know, it's idiopathic. I know for board exams, everyone thinks it's Chagas disease, that everyone goes to South America, and it's not that, but that's the most common idiopathic. And what happened is that when we talk about the treatment for achalasia, especially for a board exam now, that there are different options you could have. So let's go through these options. So if they tell you that you want to do medical management for your achalasia. Now remember, for achalasia, you want to make the correct diagnosis. You want to do a barium swallow first. I'm sure you're going to see this wonderful bird's beak sign. You know what I'm talking about. You definitely may want to do an EGD to make sure it's not pseudoachalasia or something mimicking it, like malignancy or a stricture down there. And of course, the last thing is you want to do manometry. And when you do manometry, you definitely want to measure the pressure of the lower esophageal sphincter. And this esophageal sphincter is so tight, it won't relax. And that's why food cannot go down from the esophagus into the stomach. So if you want to do medical management for this, I'll tell you one thing, it's not going to work. But what are the two categories of drugs that we use for medical management of achalasia? Well, they're drugs we use for spastic diseases. Number one, CCBs, calcium channel blockers. And number two, nitrates. And why do I say they don't work? Can you imagine if this is your lower esophageal sphincter really tight and I take a calcium channel blocker, boop, is it going to make my sphincter do this? And open up? No, but that's the right answer on the board exams if they say they only want medical management, no intervention. Now, if they do want to have an intervention, you know what I mean, beyond doing surgery, which we'll talk about soon, what are things that you could do that are minimally invasive? Well, two things jump to mind. You could do what's called a balloon dilatation. So you take an EGD, which is a long fiber optic scope, you go down the esophagus to the lower esophageal sphincter, and you open this very high pressured balloon. And now I gotta tell you, if you're gonna be doing opening up this very high pressured balloon, what's one of the risk factors of doing this pneumatic dilatation? Oh yeah, rupture. And if you rupture the esophagus, can you discharge the patient home to follow up in a few weeks? No, this is right to the OR. It's serious. So these patients definitely should be a good surgical candidate. And what's the alternative if you go down there with a scope and you don't want to balloon dilate is that you could inject a medication. What medication can you inject? Botox. Yes, it's not just for your face. I know. You love that one, huh? All right. So when we talk about, botulism toxin, Botox, yes, you could inject it there. It relaxes the muscles. But you know what the problem is? Whether you choose to do Botox or you choose to do a balloon dilatation, that you don't just do it once, you got to do it again and again. And especially with Botox, you get something called tachyphylaxis, which means that you start getting resistant to the medication. So I don't know if I want to get scoped, once a year or twice a year. Who knows? Everyone's different. So the gold standard is going to be surgery. And of course, everyone, surgery, and I don't blame you. But there is a procedure called a Heller myotomy. And what happens is that, you could do this minimally invasive. Surgeons are pretty awesome. Yes, I threw a bone to you surgeons out there, that they could do it laparoscopically, where they could do a Heller myotomy. And the old joke was, well, you correct the achalasia, now they have long-standing reflux. That's not true, because they'll probably do what's called a partial fundoplication to prevent all that reflux. So I gotta tell you that if you're a good candidate for the surgery or a good surgical candidate, it really does help out. And who does it? Cardiothoracic surgeons. Everyone thinks when you say cardiothoracic surgery, it has to be heart or lung, but you know what else is in the thorax? The esophagus. And I gotta tell you, my mom got an amazing cardiothoracic surgeon. She did a Heller myotomy with partial fundoplication, and she did great. And now, you know me, I'm all about going beyond the pearls. There is a newer procedure called a POEM procedure, P-O-E-M. That's called PERORAL, endoscopic myotomy. So these interventional GI doctors could actually do a procedure minimally invasive, just do a scope to help out people with achalasia. I think I gave you a lot of pearls today, not just for the hospital, but for your board exams. And you know what? There's a lot more where this came from. Check out my website, beyondthepearls.net. Listen to the podcast, read the books. We had this amazing quiz for the USMLE to see what type of test taker are you? If you want to find out what study type you might be, you know what? Take that quiz. Find out. I'm telling you, it's going to help you out, organize your thought process, and eventually get the score you want on your board exams. I hope you enjoyed today's Pearl.